Okay, thank you so much. I guess I just wanted to say that it's getting to work with incredibly thoughtful, compassionate people like all of you that is one of the real joys of being in palliative care. So I wanted to start with a question that maybe builds on those last thoughts, and we've sort of talked, Richard talked about nurturing the soul and the spirit of patients and families. I guess we haven't talked as much about how we do that for the palliative care team. How do we nurture our soul and our spirit? And maybe you could touch on that.
I think the answer resonates with what gives meaning for you. I know that's simple, but if you like playing a good round of golf, go do it. Relax. Life is tough, y'all. An axiom I use in my congregation is you're either in trouble, on your way to trouble, or just got out of trouble. That's called life. So do what is necessary that brings peace to you. It may not do it for everybody else, but who cares anyway? It's you. So if that means go and do some shop therapy, retail therapy, and all the ladies said, amen, right? But whatever works, and it really is as simple as that. But another component, I remember when I first started in this journey, I used to take my stuff home, and my kids were there, my wife was at the table, and we would go talk. And for the first about 6 months, they were all like, Dad, what's new, man? And after about 6 months, they kind of glassed over. Don't say that no more. I don't want to hear it. Find it in your colleagues. These are the people that do this stuff every day. I think they understand it better than even our mates do. Have those collaborative moments when you can go and, we have it in my staff. We come to my office or I go to their office and we'll have a gripe session or we'll have a cry session or do whatever we need to do to make it through that moment. We are but human. And so do whatever nurtures your humanity.
Thanks. I have one more question, and then I'm going to look first to the left side of the room for questions. And apologies if I can't read your cards, but I don't want you to feel neglected over there. I guess my last question is for Ginger. Sort of, how can we think about, and you've led a lot of teams, using teams to extend our reach and our impact in palliative care, given the workforce shortages that I think exist across the board, how can we work more effectively using teams?
So I think it's a great question. I think it's up to us to actually think outside the box on this. I will tell you that it can be anywhere from being able to sit down as a group with the interdisciplinary team that you're working on. And for example, say, we have a project that we're working on, a bereavement risk index, and anyone on the team can help with this. Who has a passion for this? Who would like to do this? Who would like to get involved? Because I think it goes back to what Reverend Freeman was saying, is you really need to tap in on passions. You need to be able to, instead of assign something, sit down with a team member and say, tell me what gets you out of bed in the morning and gets you here to work, and then tell me what gets you back after you've had a bad day. Let's talk about where those passions are. Let's talk about what your personal goals are so that we can incorporate, excuse me, personal goals with the goals that the team may also have.
Okay, thank you. We're going to open it up for questions. I see a couple on the right. Any over here? Yes? Oh. Okay. Do you have a question? No. Okay. Any questions over here? I can't see you. A couple over here. Okay, Cindy?
Thanks, Yael. Cindy Brock from the Agency for Healthcare Research and Quality. I'm actually going to build on a bit on your last question because the title of this panel was Integrated Care Teams. And I didn't hear a lot of speaking about working as a team, and particularly in light of Carol's not surprising but horrific story of spending months with her husband in a rehab facility and being unable to participate in team meetings and be considered part of the team. I'd like to hear a bit more about inclusion of patients and caregivers in teams. And from a health literacy perspective, part of the reducing of the health literacy demand on patients is not making them be go-betweens and carrying information. And I'd like to hear more about how you do function as a team to help reduce that demand on patients and caregivers, both in the hospital setting, given Bob's analogy to the band and the moving players that the team members shift all the time, as well as in an ambulatory setting. Got all that?
I'll take a jump on that, Pool. One of the, I think the metaphor that works for me is an orchestra. And in any good orchestra, there's generally only one, maybe two timpani players, but they make a big sound. And the journey that we have is that some orchestras don't value timpani players. Some of our healthcare systems don't value social workers. They don't value chaplains. They don't value those non-reimbursed entities in the hospitals. I'm an economist by training, and one of the things that I argue about healthcare financing is we are a teaching institution, and by reality, we cannot keep all the persons we train well. So we have to make one or two decisions. We either going to decide our training isn't really that good, or we're training people so well that they're going to go out and start competitive programs. I believe the latter is the reality. And so if we're not taking care of people holistically, the chaplains, the social workers, the environmental service people, the cafeteria people, if those people aren't engaged in the work of doing holistic care for that whole family, we sow the seeds of our own destruction. And I'll say it until I'm green in the face. If we don't do those things well, it won't matter how good you are clinically, because somebody else will be just as good clinically because we've already trained them. All right? So when we start talking the integrated approach at our facility, we have there are only 3 chaplains on my team, myself and 2 other FTEs. All right? We can't be everywhere. I've made the argument that we need to probably expand our staff probably about 15 folk. And they look at me like, oh, no, we can't do that. Yeah, well, okay. There's an implication for that, right? So, but we do meet in our palliative rounds. We have our palliative care physician, our nurse practitioners, our music therapy team, our art therapy team, our chaplaincy program. We get together and talk about all those kids that are part of our service, and look at ways that we could do this job better. Shortness of staff, let's just be quite honest about it, that's going to create a problem.
Could I just add a little bit up to that? I think it would be a good idea for teams to do some self-reflection on why are they resistant to patients and families being in the team. Part of it is they're afraid of them. You know, my God, we won't be able to say what we really think. Oh, you know, they'll get too emotional. We won't have to deal with it. We can't deal with it. And sometimes teams are not really clear about where their own responsibilities begin and end and how to work effectively with among the profession. So before you bring in the family or the patient, you need to have a clear structure for the team. I think that it's really important that if the patient and family want to be part of the team, it's not an obligation to be part of the team. And some people are not comfortable with it, or someone else from the family might be. I just wrote a short piece for Aging Today, and I think the title, my own title was, "There is no I in team," from my late husband's sports thing. But when you're a family caregiver, there's a you in team. you do it. So you're the outsider, you get told what to do. So I think that has to change. The reason to bring someone from patient or family is not to give them instructions, but to listen to them and have them part of the, I think that's part of the culture change.
So I'd actually like to make the point that I think the secondary palliative care consulting teams, I think they do a great job of incorporating patients and families into the decision-making process. I have never worked with a palliative care team that makes a plan outside the presence of a patient or a family member. It has to start with the patient. If they're verbal, who do you want to be at this meeting? Who do you want to be involved with your care? Who is going to be helping you at home to make decisions? If we're going to have a family meeting, they need to be there. But you're in control over who gets to help with your decision-making process. I think we do a great job of that. I think, for example, in a patient that I saw in a pulmonary clinic, had a social worker present with me. And what the social worker picked up on that I missed during that meeting was the patient's concern about the daughter being involved in decision-making. She lived in the daughter's home. She did not want the daughter to be involved in decision-making, but she wasn't able to tell her that. So the social worker picked up on this and was actually able to mine for a little bit of conflict in that situation and start the discussion. But in every palliative care discussion I've had, in every meeting that I've had, the patient and the family are forefront. They're there. They're part of the decision-making process.
I know that in Deborah Parker Oliver's work, she's used telehospice video links in the home to bring the caregivers in to the team meetings. So that way they don't have to leave the home, but they can still participate in the conversation. And so that's an innovative model there. But I think it's difficult. Some of these settings have been kind of paternalistic with strong hierarchies in place, and now we're shifting to this more collaborative team-based model. And unless you've got good buy-in at the top, I think you're just hitting your head against the wall. And we're seeing a lot of watered down versions of interdisciplinary teams out there.
Stephen.
Thank you, and I really appreciated the conversation today. Steve Rush, roundtable member. As a psychologist, I've participated in team meetings as both a professional and a patient advocate for my family. So I appreciate all the work that's been done. We've been using the definition of health literacy, which is basically access, understand, and make appropriate decisions. I wonder, is there a role for the palliative care team to help people take appropriate action?
Allow me to say something that may be a tad controversial. Most of us, at least most of in Western tradition, U.S., grew up under the golden rule, do unto others as you would have them do unto you. I think that is a flawed paradigm for medical care. Do unto others as they want done unto them. That's the platinum rule. And that's where we've got to shift. This top-down hierarchical structure of believing we understand what everybody needs and wants is a flawed paradigm. We've got to challenge ourselves to say, I want to give you what you want. And it may be diametrically opposed to what I would want for me. Barb Arnold, I don't know if he's still here, but he did a session at our hospital, and he asked the question, how many of you want to be on a ventilator? And nobody raised their hand. How many of you want to be on a ventilator if it's going to be for about a week and you get all better? A few hands went up, all right? How many of you want to be on a ventilator if it's only going to be for a couple of hours and you're going to be fully restored? Every hand went up. So the idea is it changes based on the real circumstances. Well, how do you know them? You got to talk to somebody. You got to ask. And if we don't do a good job of asking and we're just dictating, we got a problem.
So every time we get one of our teams, or I've participated in a consult to assist with discussions of treatment goals, inherently it's because there's been a problem with health literacy. It's because the information either hasn't been given correctly or it hasn't been delivered in the right fashion. So I do feel that palliative care, the secondary specialty, has a large responsibility for helping to address this issue. But I'm going to fully support what Dr. Arnold said earlier this morning, is it would be ideal if palliative care, the secondary specialty, didn't need to exist. If every one of the medical providers, whether it's a physician, an advanced practice nurse, a physician assistant, social worker, chaplain, anybody on the team, they should all have the ability to recognize when there are challenges involved with understanding.
If you're asking about whether it's appropriate for team members to kind of disclose their own preferences for care, what would you do in this situation if you were me? If it was your mother. I think there's room for that conversation. But as soon as we start talking about what is the role of team in determining or leading patients to make decisions about what is appropriate care, as soon as I hear appropriate, is that my definition of appropriate or your definition of, whose definition? And so I just want to bring it all back to the patient and really center it there, which is where I think it should be since we're talking about palliative care.
Yeah, and you bring up a really important piece. And when I asked the question about appropriate care, I expected part of that was going to be appropriate for whom. And from my standpoint, it's appropriate for the patient. And, given what I've done in my life and what you all do in your life and what we've been talking about, it's patient appropriateness, not mine.
I had a physician that told me, if our patient, an oncologist said to me, if we have a 75% chance of cure, I don't want anyone talking about death and dying. And I looked at him and I said, you just told that family there's a 25% chance they're going to die. And if they want to talk about death and dying, we're going to talk about it. He didn't like me there for a moment. But now he and I are kind of like this. Because the reality is not his journey. It's their journey. And that's a simple math equation.
Absolutely. Thank you.
Jennifer?
I wanted to.
Two Jennifers.
Oh, there's two? I'm sorry, there's one behind. Never mind. No, I defer to Craig. Sorry.
Are you sure?
Yes.
Okay, well then, I'll be speedy here.
Okay.
I'm Jennifer Cabe, and there have been some delicious morsels of hard truth from this panel, and I deeply appreciate that. Thank you. One of the things that I hold to be true is that health literacy is also about advancing self-efficacy and empowerment, and that it's a two-way street among and between the people we call patients and the people we call health professionals. So I am very intrigued by an idea that was brought up this morning about advancing health literacy about this concept we call pain management. We can still use that fancy PalMed or palliative care, all that kind of thing too, if that makes people happy. But this concept we call pain management and how little people really understand of that. Do you think, as professionals and as people who are engaged day to day in this privileged work, as each of you has described it, that it would be helpful if there were to be greater understanding through I think somebody used the word campaign, or just education, something that were to help people understand that there is such a thing as pain management. So as a pastor, if people were to come to your hospital and know that this is a thing, as a nurse, as a social worker, as a person who is advocating, as a physician, would that help? Or is that putting, as Cindy Brock spoke about a little bit, too much of the onus, too much of the responsibility on the patient who's there to be cared for, the family who's there to help the patient? What do you think?
So I'm torn. I'm torn about a campaign to educate patients about pain medication, or the concept of, yes, there are medications and there are treatments, and some treatments that does not involve medication, that can actually help with your pain, before that education is done for the providers. So it's a little bit about putting the cart before the horse again. Any type of education on pain management, on anything we can do for patients to increase their autonomy and to help them to make good decisions, I think is a wonderful idea. I just think it has to be balanced with providing education for services that may not be available where they live, or that unfortunately they may not have providers who are skilled enough to help them with that.
I think it'll be difficult to do like a public education campaign about pain medication and really see a change, but a more targeted approach for people who are in pain, or for caregivers that are caring for patients who have signs of pain or other symptoms. I think a targeted approach, well, actually we've seen that it's effective, and there are several models out there to do that. Team that I worked with from North Carolina just published in the Journal of Pain and Symptom Management on a way to address barriers to pain management in hospice with family caregivers. And we saw improved caregiver self-efficacy related to pain and symptom management, as well as improvement in patient pain. In fact, those in the intervention group had 1.5 lower levels of pain 2 weeks after the intervention. And so we're very optimistic that more targeted approaches like that will work. But I think the problem is that when you educate the public about pain medication, they may not need that information until 4 or 5 years later, or 10 years later, or 20 years later, and so it's going to get lost. But if you get the people who are dealing with it right then and right there, there are ways to open the door.
More questions, Jennifer?
Okay, well, I wanted to say thank you to John Cagle for bringing Hans-Georg Gadamer into the conversation. And so the fact that you had that slide stimulated my thinking, and that there are other areas of disciplines out there that could really inform what we do, but they're not part of the traditional mix that we have in terms of interdisciplinary teams. So I just wanted to pose a question for each of you to briefly answer one way or the other. What other discipline do you think would be helpful to bring in there, whether it's philosophy or some other? Or has there been a book or some resource that has caused you to turn on the health literacy light? Has there something come along that has helped put things together for you that you could share with us?
This may be already part of the team, but I don't think I heard it today. Pharmacy. Absolutely really important to have someone who really understands the medications and what they do and what they don't do and how to prescribe and alternate ways of delivering the medication. And some work I've been doing, family members don't get good information from their primary care doctors, but they do from a good pharmacist.
I think the aides play a vital role, those that are out there helping with bathing and toileting and the basic stuff. And really, they develop some pretty intimate relationships with the patients and with the family members. And I'm surprised we don't hear more from them in forums like this. Maybe somebody who's savvy with technology could be part of the team. I just think it's important to get different perspectives and not fall into one rut so that you can hear about other ways of doing it.
So I'm going to mimic what Carol said regarding pharmacy. University of Utah, we had a pharmacist on our team, Dr. Kenny Jackson, and he was phenomenal in helping us to not only care for symptoms, but also with education and teaching. The other thing is, and again, I'm thinking of budgets, and I'm thinking of our administrator getting ready to have a heart attack by all these different interdisciplinary team members that need to be on the team. But to be able to think outside the box, is there a way to also incorporate complementary medicine? Whether this is somebody on the team or access to someone who can do acupuncture, somebody who could do Reiki. And again, this isn't, it doesn't matter if as a provider you feel that that's a strong need for the team. It's about what our patients feel that they need and being able to have access to that. So to think outside the box, are you associated with the cancer center if you have a standalone palliative care outpatient clinic or an inpatient? Is there someone who could do Reiki healing, or is there someone who could do acupuncture at a local cancer center that could come over to see patients in your clinic or to do rounds with you one time a week, something along those lines?
So I'm going to take the prerogative. And Michael, do you want to take the last question? I've seen your hand raised a few
Thank you.
times.
I guess one thing just to share is I've always wanted to be a doctor. I didn't have a doll, Ginger. I'm very jealous. But I somehow knew that that's what I wanted to do anyway, and without the doll anyway. They wouldn't let me have it anyway. So, no, but, I think people have been way too polite. Way too polite. The doctors are bollocksing this up left and right. We have a really nice array of non-physicians talking about how nice it is to have a team. But I'm a doctor, so it's easy for me to say, you guys are being too polite. There's a lot of people who have power who are not sharing it. Not sharing it. And so there's a lot of work to be done in that space. Carol, you did say that, but you said it very politely. So maybe a few things. One of the reasons why this is, we're supposed to focus on health literacy. One of the reasons why these teams don't include patients, I mean, there's so many reasons, but just like on the literacy side, they develop their own jargon too. And it's actually, if you have non-clinicians in the group, then you actually have to look at how you communicate as a team. I actually like to throw things in just to show what ridiculousness it is. I make up acronyms that nobody knows, throw them into the team to see if anyone will call me for my BS. Nobody will, because they don't want to admit that they don't understand what I'm saying. That just shows, like, and then a couple minutes later I'll say, well, what was that, what was that acronym? What did that mean to you? And they were like, I don't know. I used an acronym NPBAH. Doesn't mean anything. No pet bird at home. There was a patient who had a possible psittacosis. Like, that's ridiculous, So the thing is, the communication issues at the team level also have to be unpacked. There's a lot of hierarchies that have to be unpacked. There's all kinds of things. And then the patients have to be brought in. Absolutely, this is ridiculous. Come on, get a little angrier.
So Michael, I'm glad that wasn't the question, otherwise we would have had a lot of time. But I will, I will ask Wilma, you have another quick question?
My question might be, is quick. And Michael, you know, wearing my interpreter hat, when you throw those acronyms in, you're making my life a lot more interesting, right? Okay, I'm just saying. So having said that, one, I just want to say thank you for bringing up the issue of self-care. Super important, super important. And so there was a reference made to some materials, written materials that are provided in Spanish, English, Chinese, and Russian. And so what I would like to hear is the interpreter part of the healthcare team when you're working with individuals, whether they're the patient or family members, caregivers, whose primary language is not English, or if they're deaf? I just put that out there because I have not heard that the interpreter is part of the team. And if the interpreter is, what preparation is provided to the interpreter, since this is a pretty sophisticated level of interpreting, since we have one foot in a few cultures and in a few different professions within those teams.
So in the best case scenario, if you are working for a large hospital organization, you have interpreters available to you. That's the best case scenario. In that best case scenario, whenever I have needed an interpreter, our standard practice is that to have a meeting with the interpreter before you walk in that room, to make sure that they have a good understanding about what we're going to be talking about and what issues we're going to be dealing with, because you're absolutely right. They need to be prepared. They need to, and in smaller communities and in smaller geographically located communities, it's not unusual for those interpreters to know the patients because it's such a small culture group. So to again make sure the first question is, are you going to have any problems interpreting for somebody who you know and have a relationship with? The mandate on us to use interpreters is extremely high. It should never be acceptable to have a family member interpret to make them responsible for delivering difficult news.
I got to do a quick
Michael,
infomercial, I'm sorry. I just wanted to mention that ARC has a Team Steps curriculum about working in teams, and there's specifically a limited English proficiency model that teaches how to integrate that interpreter and has videos of, for example, the briefs that you were alluding to before you interpret to get up to speed and safety precautions and things like that.
Y'all, thank you for moderating this wonderful panel. I really appreciate that. And Richard, Carol, John, Ginger, thanks very much for putting together a really worthwhile early afternoon. It was very, very helpful. I was going to tell a story about trust, which I'll wait for later. But Richard, I wonder if you would include trust as part of the repository of meaning making that you talked about before in terms of spiritual. And I'll let you think about that. Maybe a little later I'll bring it up at the podium. Thank you all. We'll take a 15-minute break and come back at 3:05.